Hello and welcome to Wellness Live. My name is Dr. Olivia Moses and I will be your host today for today's session. Now, if you are watching us live, this is the session that you can ask questions live of our expert guests. So here at Loma Linda, we have a number of specialists here and wonderful doctors that you can come and see. However, we also like to celebrate certain months that are dedicated to health. And February, if you're watching us live, we are February 2023. February is American Heart Month. And we focus on watching and paying attention and learning about heart health. Now, when you look at epidemiology and statistics, you or someone you know probably has had some type of heart issue or heart condition or has worried about their heart at some point in time. So today we have a very special guest to actually talk to us about hypertension. Dr. Giv Heidari is a cardiologist here at the International Heart Institute here at Loma Linda University Health, and he serves as the director for our hypertension clinic. And he's going to give us some really great information on hypertension, which probably is a topic that you or someone you love needs to know about. So without further ado, I'd like to introduce you to Dr. Giv Heidari.
Thank you, Olivia, for your kind introduction. It's an honor for me to be here. And as you mentioned today, we're going to discuss about management of a very common condition, hypertension. We're not going to only cover the pharmacological part of management of hypertension, but we also would like to discuss about non-pharmacological approaches as well, which is called lifestyle modification, which is sometimes, not always, the forgotten part of management of hypertension. So let me just share my slides with you guys. Can you see it?
Yes.
Okay, so here are our learning objectives. We would like to define hypertension in this presentation and how to diagnose it. Also, we would like to identify the treatment threshold for a certain group of patients we may need to have more intensive blood pressure control. Our goal is also to discuss the pharmacological and also non-pharmacological management strategies, including diet, weight loss, exercise. And if we have time, I would like to discuss a little bit about the shared decision-making and the management of hypertension too. So a couple of key points why hypertension is important. So hypertension is a very prevalent disease. The data I have is for 2017. It shows that the prevalence of hypertension among US adults is more than 45%. So it's really, really prevalent. And if the older you get, the higher the chance of developing hypertension. So if you see, for example, the same data for people more than age of 60 is probably even more common. It's good to know that management of hypertension is the most common reason for office visits in the United States, excluding the office visits for pregnancy-related issues. And then there's no doubt that all of us knows that hypertension is a known risk factors of developing heart attack, stroke, cardiovascular disease. It's been shown that increasing of 20 millimeter mercury of systolic blood pressure or 10 millimeter mercury of diastolic blood pressure will increase the risk of death, all-cause mortality by 2 times. So other important issue about hypertension is if you look into the resistant hypertension, the proportion of people with resistant hypertension, it's been increasing dramatically. So comparing the mid-90s to mid-2000s, the prevalence of resistant hypertension, or proportion of patients with hypertension who have resistant hypertension has increased from 14% to 24%. I'm sure that if we can do the same study these days, it's going to be even more than 24%. And the good thing about this is if these patients shows up in hypertension clinic or in any clinic which deals with hypertension, there's 50% chance that we find a secondary reason for hypertension in these population. In order to be able to manage hypertension, we need to first define hypertension. So you may use different guidelines to define hypertension. The one which I'm using here is the 2017 American College of Cardiology, American Heart Association guideline for hypertension. There might be a little bit difference between the thresholds to define hypertension between European guidelines, American guidelines, or even different American guidelines. But this is one of the latest one, and it includes the latest trials, which might not necessarily be included in other guidelines. The one of the most important one, which some people may use, that is called a Joint Commission number 8 guidelines, JNC guidelines, which there's a little bit difference between the two, but the latest trials are not included in JNC. That's why me and most of the cardiologists, we use the ACC guideline. So I would like our audience to take a look and pay attention to this table. The reason is, if you look into the definition of normal blood pressure, you would see the systolic blood pressure here should be less than 120. So if you check your blood pressure at home and you figured out, for example, your blood pressure is in 120th range, like 125/70. So by definition, you have elevated blood pressure. So you could see the threshold is very low. So normal blood pressure means systolic blood pressure of less than 120. When it comes to elevated blood pressure, you might have systolic blood pressure of between 120 to 130. And diastolic is still less than 80. So diastolic is the bottom number. Systolic is actually the top number. What is important here is, if you start to have elevated blood pressure, that's the time that you need to start treatment for that. So that treatment is not necessarily pharmacological treatment. It can be just lifestyle modification. So what is the threshold to diagnose hypertension? It's actually systolic of more than 130. And we have two stages for hypertension definition, stage 1 and stage 2. So anything more than 140 on the top number and 90 on the bottom number is called a stage 2 hypertension. And why we have a stage 1 and a stage 2, it's because some people might have some comorbidities or some medical conditions which put them at a higher risk of developing cardiovascular disease. So for those patients, pharmacological therapy, the threshold to start that would be at the stage 1 of hypertension. I have more slides on that. We can discuss more. Needless to say, diagnosis of hypertension is not just one-time checking of your blood pressure. So many people can check their blood pressure at home. So I can tell you how we can diagnose it with checking blood pressure at home. But if you just consider the office visit check of your blood pressure, it should be at least twice check of blood pressure in 2 different occasions. Some guidelines mention it should be at least 3 times. So 2 to 3 times is needed to check your blood pressure. And it should be more than the threshold, which I mentioned in the last slides, to call it hypertension. It's not just based on one-time checking. If you are checking your blood pressure at home, what we usually suggest is at least 1 week of checking your blood pressure, twice daily, once in the morning, once in the evening. And then we usually average the numbers. Some guidelines, again, they mentioned 2 weeks. So 1 to 2 weeks of checking of blood pressure at home, average that. And if that average is more than the numbers, which I mentioned in the last slides, then we can make the diagnosis of hypertension. Again, keep in mind, checking of your blood pressure has technique. It's not a difficult technique. It's something that we need to pay attention to that. So whenever patients come to my clinic, I would like them to sit and relax, at least for 5 minutes. Because whenever you're just walking and we want to check your blood pressure right away, it's going to be elevated. So we want our patients, we want our people checking blood pressure at home just to relax. Just sit down with a supported back, use the right cuff size, because if you use a small cuff size, it's going to show your blood pressure higher. And as I mentioned, if you're in the office, we need at least twice in the separate occasions. But even the first time you're going to check the index measurement that we're doing it the first time, it needs to be at least 2 measurements, 30 seconds apart. Because we want to make sure that we're measuring the blood pressure correctly, because we're not going to start pharmacological therapy for someone who really does not have hypertension. So we check it twice, 30 seconds apart, and we need to make sure that the difference between the 2 numbers are within the maximum of 5 millimeter mercury difference. So imagine we're doing it in the right way, and then we check it at least twice or 3 times in the office or for a week or 2 at home, and then we figure out, we passed the threshold. Now it's the time to manage that. So I brought up in the prior slides that hypertension has 2 stages, stage 1 and stage 2. So what's the difference between the 2? So stage 1 of hypertension, stage 2 of hypertension, then just focus on that, is when the blood pressure is equal or more than 140/90. When we have a stage 2, that's the threshold to start pharmacological treatment. So what about the stage 1? If you have a certain medical condition, the guidelines suggest that the pharmacological treatments needs to be started at the lower threshold, which is basically stage 1 of hypertension. So you may ask, what are these medical conditions? I try to summarize these conditions here. So diabetes is very common. If you have diabetes, if you check your blood pressure, and if your systolic is probably 132, for example, over 82. So we use the highest number to basically categorize the blood pressure. If your blood pressure is as much as at least 130 or above, then you have a stage 1 hypertension. If you have diabetes, so you fulfill the criteria to be started on pharmacological treatment. It's not just diabetes. I just summarized the other medical conditions. Chronic kidney disease. If you have a renal transplant, if you have a transplanted kidney, if you have heart failure, if you have a stable ischemic heart disease. So you may ask how we can diagnose this. So if there is an angiogram or coronary CT scan which shows you have a significant plaque, we have to diagnose this. But basically, if your cardiologist, if your physician labeled you as having ischemic heart disease, then you need to have a lower thresholds to be started on pharmacological treatment. Peripheral arterial disease. If you have a leg pain when you walk, and it's because of you have plaque and atherosclerosis disease of your leg arteries, then you need to start this at the sooner time, at the lower threshold. That's a stage 1 threshold. There's also a risk factor calculator that we use it in our office. It's called ASCVD risk calculator, atherosclerotic cardiovascular disease. It's very easy. You guys can just Google it. Just go to Google, search ASCVD risk assessment. There's a calculator. All it needs is your age. It works for people more than age of 40. So all you need is your age. It'll ask about your blood pressure number, systolic and diastolic. It's going to ask for your total cholesterol level. It's going to ask for your HDL, smoking, and then it's going to give you an estimate of your risk of developing any major adverse cardiac events, which means heart attack, heart failure, stroke, even mortality within the next 10 years. So you will get a number. And this basically comes from a very, very big study, which was called the Framingham study. So this is basically a modification of that risk stratification model. So if that risk stratification is more than 10%, then you also need to treat your hypertension at the stage 1 with pharmacological therapy. ASCVD risk score is not just for hypertension. It's very common that we use it at the time when we would like to see, for example, someone needs to be started on cholesterol medications too. At that time, the cutoff point is 7.5. And also for elderly patients, if they're ambulatory, if they're non-institutionalized, if living in community, then we also would like to be a little bit more aggressive. So we start treatment on a stage 1 of hypertension. This is a little bit area of debate. In the prior guidelines, particularly in JCN guidelines, they mentioned that older people can be a little bit liberalized on controlling of the blood pressure. There were some trials who came after that, like sprint trials, which actually showed the opposite. So at this point, at least I can tell you, based on the guidelines that we have for ACC, elderly people, if they are ambulatory, if they're not frail, and if they're good, then we can go with the stage 1 treatment of hypertension with medications. The only medical condition which came to my mind, which is very important, but it's not basically follow the rules for medical conditions that the patient might have, is basically secondary prevention of a stroke. When we say secondary prevention, we mean that patient had a stroke at some time, and now patient's trying to control the blood pressure after a stroke. For secondary prevention of a stroke, based on the guidelines, we go with the stage 2 if we would like to start medical therapy. So this is the summary of the same thing. If you see, there are several conditions which I described in the last slides. If our patients have one of these conditions, then we need to be a little bit more aggressive about the timing of treatment of the pharmacological therapy. One thing that you could see here is, irrespective of the risks, if you start pharmacological therapy for hypertension, the goal of treatment should be systolic of less than 80 and systolic of less than 130 and diastolic of less than 80. So if we commit to be started on the pharmacological treatment of hypertension, which means that drugs, basically, medications, basically, then our goal would be less than 130 over 80. So if you are taking medications and you're home, you're checking your blood pressure, if your blood pressure's average, daily average is 135, for example, over 85, you're not at goal. So you need to talk with your physician and then discuss about making some changes. So these changes can be pharmacological, can be lifestyle modification, which I have the slides about that. I thought that it might be important that we discuss about the white coat syndrome or white coat hypertension as well. It happens to all of us. If we go to a physician office, even our blood pressure has always been normal, we see that the numbers are actually a little bit elevated. It can be for people without hypertension, or it can be with people with hypertension too. So we can have a patient with a diagnosis of essential hypertension and some white coat component, and also we can have a patient without diagnosis of hypertension and white coat syndrome. So for some reason, people might be a little bit stressed out, so blood pressure number is a little bit elevated in clinic. It's easy to describe this, but honestly, it's not sometimes easy to diagnose this. The gold standard of diagnosis of white coat hypertension is 24-hour ambulatory blood pressure monitoring, which actually checks patients' blood pressure every 30 minutes at home. And then when patients comes back to our clinic, we look into the average numbers, the daytime average number, and then there's a cutoff for that. If that cutoff is passed, then we have the diagnosis of essential hypertension. But if that cutoff is not passed, we would say the reason your blood pressure was high in the clinic is because you had white coat syndrome. It's very, very common. As you see, it's 10 to 20% of patients who come to your office might have white coat hypertension. So with this introduction, I'm just going to go to the management of hypertension. There are two ways to manage hypertension. They go hand in hand. It's not like we go with lifestyle modification, and if our patients have indications to be on medications, we try not to start that. No, if our patients pass that threshold for pharmacological therapy, which I explained in prior slides, we go with pharmacological therapy. And it's with the lifestyle modification. So it's not like, so whenever you have pharmacological therapy, it should be with lifestyle modification. So just to summarize, so we have these categories of hypertension. If we have an elevated blood pressure, which is going to be something very, very common, then we need to start with lifestyle modification. So because the threshold for pharmacological therapy is not yet passed here, so lifestyle modification or non-pharmacological approaches would be enough. If we have someone who has a stage 2 hypertension, irrespective of the risk factors, patient needs to be on medical therapy. And it's going to be medical therapy plus lifestyle modification. So it's going to be both approaches. If you have someone with a stage 1 hypertension, if there is one of those medical conditions, which I summarized before, then patient needs to be started in medical therapy too, plus lifestyle modification. And as I mentioned before, when we commit with medical therapy, then the blood pressure goal should be less than 130 over 80 millimeter mercury. So you may ask, what are these lifestyle modifications? I'm just going to focus on most of these categories that you see here. Weight loss, diet. I put DASH diet because most of the studies have been on DASH diet. I'm going to explain a little bit more in the next second part of this presentation. Reduced sodium intake is very important. Enhancing potassium intakes. Many of us may not be aware of that, but taking foods which has more potassium content is actually going to help with lower the blood pressure. Exercise or physically being active, it's going to help with the control of the blood pressure too, and reducing alcohol intake. I think this is the last slide I have for the first part of this the discussion, this presentation. I would like the audience to look into this slide. It's very important. So if you see, the intervention is actually on the left side. This is the lifestyle modifications or interventions that we can start in our life to control the blood pressure better. A little bit more description here. And at the right side, you can see how much effective it would be if you start this modification to lower our systolic blood pressure. Just by first glance and looking to this table, you would see the most important or the greatest impact comes from the healthy diet. If someone's having a healthy diet, which here in this example is going to be DASH diet, which is rich in fruits, vegetables, whole grains, there's low-fat dairy products, and reduced content of saturated and trans fat, then if you have hypertension, the average, you can have on average 11 millimeter mercury, you can drop your systolic blood pressure. So it's average. So some people might be more, some people might be less. So most of the studies that's been done on lifestyle modification, they just focus on one change. It's very difficult that you do 2 or 3 changes and look into the results of that. So just imagine if you go with a healthy diet and also you go with weight loss, which probably comes after a healthy diet, you actually can kind of augment the effect of the healthy diet. So healthy diet has the biggest impact on hypertensive patients. A normotensive patient, it has less effect. After that, physical activity, aerobic exercise. I'm going to explain this in more details. You can lower your blood pressure systolic on average 5, and if it's going to be really vigorous exercise, then you can lower it to even 8 milligram mercury. So that's going to be probably the second most important intervention we can do. Again, we can see weight loss. We can see all other interventions that we can do to lower our systolic blood pressure. One thing I would like to emphasize here, because I thought that there might be not much time to put it as a separate slide, but looking to the dietary potassium, 3.5 to 5 milligram per day, it's the suggested consumption of potassium a day. And this is not by medication. It all comes by diet. So like diet, which is rich in potassium, then you can lower your blood pressure by 5 millimeter mercury systolic blood pressure. And also, again, look into it in conjunction to each other. So it's not just the potassium hydrate. If someone's going with potassium, they may go with low sodium as well. So you can beautifully decrease your blood pressure. So I'm going to stop by here and we'll be happy to answer the questions.
Thank you so much, Dr. Heidari. You actually covered a lot of ground in this first half. So a couple of questions. So in summary, though, we have numbers when it comes to hypertension. You go to your doctor, you have these numbers assessed. Your doctor will actually put you into a category of hypertension or normal or healthy blood pressure. And then based on those numbers, you're going to have medication or some type of lifestyle intervention from there. So with that being said, in the summary of what you talked about, you also mentioned what you called resistant hypertension. So I had a question regarding that. Could you define resistant hypertension? And does your doctor diagnose you with that?
Of course. So in the second part of this presentation, I can focus more on that. But resistance hypertension is basically if you are on 4 blood pressure medications, or you're on 3 blood pressure medication and your blood pressure is not controlled, at that time we call it resistant hypertension. But that's a definition of resistant hypertension. And one thing about resistant hypertension, which I can add, is if we have diagnosis of resistant hypertension, just one medication is not going to help. So at least 2 medication. And I mean, imagine that we have someone who is really intensively doing a lifestyle modification. They would like to lower their blood pressure without using too many of medications. I've never seen someone with resistant hypertension with less than 2 blood pressure medications.
Okay. Thank you. That's extremely helpful. We have actually some questions coming in. So please go ahead, continue to ask Dr. Heidari questions. This one actually very interesting. This is asking about why is there a fluctuation in blood pressure between day and nights?
Yeah, that's a very good question. Blood pressure control is not under control of, the nervous system that we have basically control over them. So blood pressure is mainly because of the flow, the amount of the flow we have in the vasculature, and also it's also related to the tone of the vessels. So, or basically the resistance of the vessels. So tone or resistance of the vessels comes from autonomic nerve adjustment. So you have sympathetic nerves, you have parasympathetic nerves. So the balance between the two makes the resistance of the vessels inside your body. So you don't have any control over that. So when you go to sleep, we call it more vagal, phase of life. So there's going to be a parasympathetic predominance. So the vessels are a little bit more, less resistance, basically, you can call it that way. So the blood pressure usually drops. This is for the normal condition. If someone doesn't have any medical condition, particularly obstructive sleep apnea, when they go to sleep, blood pressure drops. So you have lower blood pressure number during the sleep. But some people might have a condition which is called sleep apnea. Sleep apnea means for some reason their oxygen saturation drops. They might have some pause in breathing, so they may wake up in the middle of the night several times, and they may not remember that. Whenever they wake up, the sympathetic tone actually increases. So that increases their blood pressure. That's why obstructive sleep apnea is a condition that you may see opposite to what you would see in a normal population, that during your sleep, sometimes the blood pressure average is even higher than during the day.
Okay, thank you. So basically, differences between day and night is an absolutely normal phenomenon.
It's normal. Yeah.
Okay. We have another question coming in, and you talked a little bit about white coat syndrome. And so this is asking about advice with basically what happens when I take my blood pressure during the day and I'm completely normal. However, when I go to the doctor's office, I'm now in hypertension levels. What advice do you have for someone like that?
Yes, so it can be a classic white coat syndrome there. So number one, we need to make sure that your blood pressure machine at home is calibrated and it's working well. So my suggestion is at least one time you can bring your machine to the doctor's office and they can check it with the blood pressure machine that they have in the office. If it's really shows that the numbers are the same, so that can be a definition of white coat syndrome. So white coat syndrome means your blood pressure is elevated in the office of the doctor, not super elevated, just not more than 180. And then in some guidelines, it says not more than even 160 systolic. And usually our patient does not have other findings related to uncontrolled hypertension. We call it target organ damage or end organ damage. Like, for example, there's no history of a stroke. There's no history of heart failure. There's no history of heart attack. So if you don't have history of any of those things, your blood pressure at home is perfectly controlled with the numbers which I brought in the table, but your blood pressure is high in the office of the doctor. That's the definition of white coat syndrome. To have a better diagnosis, as I mentioned, the gold standard intervention we can use is 24 hours blood pressure monitoring. So you can ask your doctor to provide this for you. We have it in International Heart Institute if you're interested on, and then you can have it at home because it's going to check it every 30 minutes, and we're going to look into average of that. It's mostly not related to, for example, different conditions like stress conditions or such a things. So it's going to be very helpful. It's gold standard, and it shows that it has a higher correlation between the 24 hours blood pressure monitoring and the complications of hypertension in the future run.
We have a number of questions coming in, and I don't know if we're going to have time for all of them, but we have another one, and this kind of goes to your topic, I think, of resistant hypertension. We have a question here about they take 2 different medications for their hypertension, but still have stage 2 hypertension. What would your advice be for an individual like that?
Yes. So imagine that every measurement is correct. As I mentioned, that's number one thing. Imagine all the measurements are right. So if someone's really have uncontrolled hypertension, which means that stage 2, despite being on at least 2 medications. So number one, we can see if we can intensify the lifestyle modification. Okay. Because imagine if this 145, 144 average of close to 140, I prefer to try to lower it with a lifestyle modification if it's doable. But if I see that our patient is actually trying their best and it's not achievable, then probably we need to go for a second agent. So hypertension is one of the biggest risk factors for development of cardiovascular disease. So I think it needs to be well controlled, and we need to have commitment on the using of pharmacological treatment. So if you have good adherence to medications, good adherence to lifestyle modification, patient has good motivation, and still the blood pressure high, it means that we need to either increase the dose or add the third agent. Okay.
And we have time for one more. And you had mentioned potassium in your presentation. So Dr. Heidari, the question is, are potassium supplements effective?
Yes, so it's a very, very good question. So I'm happy that you bring up this question. So I'm not suggesting recommending potassium supplements. So potassium supplement is not studied on management of hypertension. We're just talking about the diet. So you need to increase the intake of potassium with diet. I don't think it's safe if we go with potassium supplements, particularly in patients with chronic kidney disease. And again, we're not just treating hypertension, we're treating the patient as a whole. We need to look into other medical conditions which might be there. If I have a patient with chronic kidney disease at stage 5, I don't suggest them to go with high potassium diet. So we need to look everything into the content, into the right content. So if I have a patient with good kidney function, I will suggest diet to increase the potassium. I never suggest supplementation of potassium because it's not been studied. It might not be safe, but diet is always good.
Okay. Well, we are running very short on time and we have more questions, but Dr. Heidari, why don't we get to the second half of your presentation? Hopefully we'll have time for a few more questions.
Of course. So you guys can see my slides, right? Okay. So the second part, I try to focus on the management mostly. Here I would like to discuss about the effect of weight loss. So there's no doubt, all of us know that obesity increases many comorbidities, including cardiovascular disease, including hypertension, including developing CKD. Mortality actually has a direct correlation with obesity. And this relation is actually progressive. So the more obese, the more it would be the risk of developing any of these risk factors, any of these risks, basically, or endpoints, basically. You may ask, what's the definition of obesity? So studies use different definitions for obesity. So they use weight, just if someone thinks that he or she is overweight.
Dr. Heidari?
Yes.
Oh, I'm so sorry. Could you re-share your slides with us?
Of course. Can you see it now?
Yes, thank you.
No worries. So definition of obesity can be just by weight, can be by body mass index, can be just by the fat circumference around your hip. So if you think, or your waist, basically. So different study uses different definitions for that. But if we think that someone is obese, we definitely suggest that they lose weight, because this is one good way to try to lower the average blood pressure in that patient. You may be interested why obesity may increase the blood pressure. There are two main reasons: increase in systemic vascular resistance, and also effect of the metabolites because of, secondary to obesity and the renin-angiotensin-aldosterone system. This is I'm not going to go to details of that, but this is a very important system or axle in the body that many of the blood pressure medication actually works on this system. So this graph, I took it from New England Journal of Medicine, 1999. It's a study. It's a very nice study. It's a cohort, basically, a study. They looked into women and also to men, middle-aged. So I think probably women, if I'm not mistaken, their average age was, their range of age was 35 to 55, and for men it was 40 to 60. And they followed them more than 10 years, something like 15 years. And then they looked into their risk of developing diabetes, hypertension, gallstone, or coronary heart disease. They looked into it, or they divided the patients having different BMI, basically body mass index, which is one of the index which shows how obese our patient is. So if you see, for example, for people with BMI of less than 21 after 15 years, I think it was something like 15 or 18 years, you would see, if you go, for example, BMI of 22, you would see just by increase in age, they have higher risk of developing diabetes. They have high risk of developing hypertension. This dashed line, blue dashed line, is hypertension here. But you see that it's proportionate to the BMI. If we have an obese people, which is defined by BMI of more than 25, the risk is actually more, and it's proportional to the BMI level. Same thing for men. So that simple study, it's a simple result, but honestly, it's a beautiful study. They followed patients for 15 years. It shows to us that increasing body mass index has a direct relation with many of the comorbidities, as I summarized here. So the question is, how can we have this weight loss intervention? So different ways. Nowadays, weight loss surgeries are very popular, and sometimes we use drugs as well. I'm not expert in weight loss, but one thing that we can suggest to our patient is behavioral weight loss. Most of the studies is actually on behavioral weight loss. Behavioral weight loss, the focus is not on specific diet, but the focus is on reduction of the total calorie that you intake and increase the physical activity that you do. And it shows that it not only can improve the hypertension, it also can prevent developing hypertension. This is the biggest study for behavioral weight loss intervention. And as you could see, the more you lose weight, the biggest is going to be the effect of your blood pressure reduction. So if you lose something like 8 to 9 pounds, you would have an average of 7 to 8 millimeter mercury drop in your systolic blood pressure. If you gain weight, the systolic blood pressure may go up. So also, there's another big study. This is called Framingham Heart Study. It's a very famous cardiology trial, basically. It shows that if you have sustained weight loss, they use sustained because there's some recent study. I'm not going to go to details of those, but it shows that weight loss through surgery, it's very good. I mean, weight loss through surgery have many, many benefits. Our focus here is on just hypertension, but it shows that it's not sustained that much in effect of lowering the blood pressure. But if you go with just behavioral, which means losing weight, and try to sustain that, if you do it at least close to 7 kg or kilograms, which is something like 15 pounds, it is associated with 22% reduction in developing hypertension in overweight patients when they're younger, and when they're older, between age of 50 to 65, it's going to have even more effect. So it decreases the risk of developing hypertension, which is significant, actually. So we're going to switch the gears to diet, and we'd like to see how much diet is going to be important to reduce the blood pressure. As I mentioned, some specific diets, they showed that they have the biggest impact on lowering the blood pressure, which is the DASH diet. I have a slide about that. I categorize this to low salt diet, but I mean, you can see it can be a different intervention too. You can go with a DASH diet, for example, and you can go with low salt as well. High potassium diet, which we discussed briefly about that, and also specific regimens. So we have a DASH diet, which is actually an acronym for dietary approach to stop hypertension. And then we have vegetarian diet. So many diets. I'm not going to be specific about every single of them. But the latest study, there's a meta-analysis on 41 studies on different diets. There's lots of studies on that. Number one, it's very difficult, actually. So just keep that in mind. So these numbers are not written in stone. So this is just a study. It's just a meta-analysis. It might be a little bit different than this, but we know that all of them are helpful. So the meta-analysis on the 41 studies shows these two diets has the highest and the biggest impact on lowering the blood pressure. We have vegan diets too. We have diets, which is not necessarily these diets as well. If you look into that, there might be many of them. There might be helpful as well. But these are the two with the biggest impact. So let's just focus a little bit on the sodium restriction. As you see on the title, I just put it 1.5 to 2.3. There are different studies. There are different cutoff points to use. I didn't want to just go with just one number. That's why I put 1.5 to 2.3. So we need to try to lower it less than this number. So at least less than 2.3. I think 2.3 is a WHO suggested number for this, or recommended number for this. No doubt, people in the US, they use salt more than the average or the recommended numbers. So the average use in the US population is 3.6 gram of salt, actually sodium, gram of sodium a day. So I have a slide about that. We can look into it into more details. And also keep in mind that response to restriction of sodium is very variable between people. It's actually very variable depending on your baseline blood pressure too. If you have hypertension, high blood pressure, the effect of sodium restriction is higher than if you have, for example, just elevated blood pressure. The effect is going to be less at that time. And needless to say, we're not just talking about hypertension here. Sodium restriction also has other good effects on the health, which we know about this. So it's not just a blood pressure control. So this is the data that I wanted to discuss. So this shows the amount of sodium intake in the US population, male and female. Mostly male uses more salt because they eat more, basically. And then when you eat unhealthy, then your salt content is going to be higher. As you could see, starting from age of 4, US population uses more than recommended sodium intake, which is 2.3 if you're going to see the highest, actually, the cutoff. and it's continuous even after age of 71. So this is the wrong dietary habit that we use. We need to try to lower it, actually. And then I tried to figure out what is the reason for that. So I thought that maybe it's not a bad idea if you look into the source of sodium in diet. So naturally, the sodium in the diet, in the food that you take, only comprise 4% of the sodium that you take. If you use a processed food that you find from grocery, it actually includes 68% of the sodium content in your food. If you go to restaurant and you take meal there, it's going to include 15% of the sodium content of your food. So if you put it together, something's more than 80% of the sodium that you take is basically coming from the processed food or coming from the food which is not a homemade food. So if you just want to comply with low sodium diet, you need to make sure that you cut down the amount of the processed food you take and cut down the amount of the meal that you take in the restaurants if you're not sure that that meal is healthy with regard to the sodium content. So this is a very famous study. It's called DASH diet study. So they tried to give low sodium diet and DASH diet to people, followed them for 3 months, and see what is going to be the effect of diet, sodium, specific diet, which is DASH, sodium, and combination of both and lowering the blood pressure. And as you see, I mentioned that there's a variable response. As you could see, if someone with a normal diet, not a DASH diet, if they try to lower their sodium intake from a high level to intermediate level is the goal of WHO, is 2.3 gram a day. You could see, and there's an average of only 2 millimeter mercury drop in systolic blood pressure. But if you lower it, if you restrict it even more than that, you have even a better response. You would see the average is something close to 5. And this is for people who are using a non-DASH diet. So DASH diet per se might have less sodium in it too. So if you have a DASH diet, the effect is less pronounced. But the thing is, if you go with a DASH diet and if you go with the low salt diet, you'll reach to this part of the graph, which is you can see you can decrease your systolic from mid 130s to mid 120s. And then again, this is just the diet and sodium. If you start to do exercise, if you do other lifestyle modification, you even can lower it more than this. So we talked about DASH diet a lot. So this is the slide that I would like to focus on. So the study was for late 1990s. So it's an older study, but still this is the best regimen so far, which shows that has the highest impact on lowering the systolic blood pressure. So they divided people into 3 groups of diets. The diet which was low in fruits, vegetables, legumes, and high snacks. High snacks, sweets and meats, and also saturated fats. There is a second group of people which they started to be more healthy, and they go with just fruits and vegetables and low snacks and sweets. And then there's a third group, which they call a combination diet, which is the same diet which we call the DASH diet. They try to add a little bit of both. So they go with fruits, vegetables, legumes, low-fat dairy products, low in snacks, low in sweets, low in meats, low in saturated and total fat. So basically, one example of the diets that he put in the study is 4 to 5 servings of fruits, 4 to 5 servings of vegetables, 2 to 3 servings of low-fat dairy per day, and also less than 25% of the consumption, the whole food or the portion is by fat. So this is the biggest impact which I mentioned earlier. So out of these 3 groups of patients, if you just go with fruit and vegetables, that's going to be helpful. It's going to lower your blood pressure, systolic blood pressure by average of 4. But if you go with DASH diet, it's going to be close to even 12. So that's the significant biggest impact that we see in lifestyle modification. Again, I need to emphasize here, this study is old. If you do the p-value is positive, that means that it's going to cover the confidence interval as well. If you repeat this studies 100 times, 95% of the time, the number is going to be something ranging between probably 8 to 13 or 14. So it's definitely helpful and important. But I just want to tell you that That does not mean that other diets that we are used to it is not helpful. They're also helpful. But there is a trial, there's a study which shows this diet has been more effective. So again, we're going to shift our gears. We're going to go to physical activity and its effect on the blood pressure. This is probably the most difficult intervention for a study. It's very difficult to design a study that's check the physical activity and type of physical activity of people to see how it's going to affect the blood pressure. The biggest study is done on dynamic aerobic exercise. So as you guys know, we have isometric or dynamic exercise. We have isotonic exercise. We have aerobic exercise, and we have resistant exercise. So if you do a dynamic aerobic exercise, such as brisk walking, such as jogging, such as dancing, bicycling, swimming, or using certain equipments like elliptical machines, these are the best exercise to lower the blood pressure, and the biggest data is behind this. Again, it's not very easy to design a study that 100% check this, but at least the best data we have is here. And it shows that it may on average lower the systolic blood pressure by 5 to 6 millimeter of mercury. So because it's very difficult to come to a conclusion, I use the AHA, or American Heart Association, goal for dynamic aerobic exercise. So based on the AHA goal, at least 150 minutes of moderate intensity physical activity. Or if you would like to go with vigorous intensity activity, at least 75 minutes, which means approximately 30 minutes per day for 3 or more days in a week. Then this is the defined dynamic aerobic exercise by American Heart Association. So this is something that I always suggest my patients, every patient with hypertension comes to my clinic. Do either moderate intensity, or if you're able to do vigorous, do the vigorous. You may ask, okay, what is moderate? What is vigorous? Rule of thumb, if you're doing a moderate intensity exercise, you are able to talk. You're not able to sing, but you're able to talk. Imagine you're doing a brisk walk with your friend, you're able to talk. You're able to initiate a conversation with your friend. But if you go with vigorous exercise, you're not able to talk to your friend, just a couple of words, nothing more than that. So if you're doing an exercise that you're not able to talk, because breathing is very important in that exercise, that's a vigorous exercise. We have a better definition for that based on METs, or the amount of metabolic or energy that you use for that. But as an example, if you do walking very brisk, which means with the rate of 4 miles per hour, that's a moderate intensity physical activity. Mowing lawn, tennis, playing doubles, bicycle with light effort, which means 10 to 12 miles per hour, then you're doing moderate intensity. Vigorous intensity means hiking, means jogging. You have the speed here, 6 miles per hour. Fast bicycle, 14 to 16. Basketball, soccer, tennis, single. So these are the vigorous exercise. So this is the recommended exercise to lower your systolic blood pressure. Okay, you may ask about other type of exercise.
Dr. Heidari, I'm so sorry. We are running out of time, so I just wanted to do a time check with you.
Sure. So I can finish in a minute if that works.
Okay, perfect.
So we have dynamic resistant exercise. We have isometric exercise. You can see the exercise. There's not well studies because it's very difficult, and their effect is usually modest effect. So if you would like to choose, go with dynamic aerobic. So pharmacotherapy of blood pressure, you guys all know that we have first-line agents. I'm not going to go into details of that. We have diuretics. We have ACE or ARBs like losartan, like lisinopril. We have calcium channel blockers like amlodipine, nifedipine. As I mentioned before, if initial blood pressure is more than 160 or 100, guideline-based, we go with 2 agents. Same day in the office, your doctor may prescribe you 2 agents. We usually reassess in a month. If it's good compliant, blood pressure is not controlled, we add the second agent. We also need to consider the medical conditions to have our thresholds of starting this. Specific groups might need different medications. People with heart failure might need beta blockers. People with a condition which is called heart failure with preserved EF, which means a stiff heart, they may have a volume control. They may need diuretics. People with diabetes, if they have protein in the urine, they may need more of ACE or ACE inhibitors or ARBs like losartan and lisinopril. And people with a CKD, it's with protein in the urine, they also may benefit from these 2 agents. Also, always consider when someone comes with hypertension or having hypertension, it's a good time to look into other different conditions in that patient. So these are the workup that we usually suggest if someone shows up for the first time in my clinic or any hypertension clinic. We need to make sure there's no other risk factors like diabetes, like metabolic syndrome. So we need to make sure there's no target organ damage. So we need to do EKG. We need to check out back of the eye. We talked briefly about the secondary hypertension. I'm not going to go into details of that. But if you have someone who has abrupt onset of hypertension, if someone who has resistant hypertension with that definition, which I mentioned, if someone has an onset of hypertension less than age of 30, and many other conditions, which you can see the summary here, we need to think about a secondary cause of hypertension. What are the most common cause of secondary hypertension? Secondary means there's other disease which has hypertension as a side. There might be an increase in a specific hormone. The most common one is use of other medications like steroids, like NSAIDs, like ibuprofen, for example, like oral contraceptive pills. Other common etiologies are sleep apnea. If you have increase in a hormone which is called aldosterone hormone, if you have kidney disease, or either the parenchyma of the kidney or the vessels which is feeding the kidneys, these are the secondary cause of hypertension. The doctor needs to be aware of those in these conditions, and we needs to do an appropriate workup for that. And this is the last slide. I just want to emphasize in this. So treatment of hypertension is not just treatment of numbers. It's treatment of patients. When patients come to my clinic, I consider them as a human who makes decisions for themselves. It's not like they come to my clinic, I see the numbers and I write the medication. It's not the case. We need to have a conversation. I need to know patient's preference. I need to know patient's beliefs. I need to make sure that I prioritize that belief. I prioritize that preference. Some people might not like too much of medical medications. Some people might not be too much familiar with lifestyle modifications. There might be some barriers here. We need to know about those barriers. It can be as simple as a language barrier. It can be as simple as the patient wants the family member to be with him or her to participate more in that. There are studies here shows that definitely shared decision-making improves the patient adherence and improves the outcome of hypertension. Sorry, it took a little bit of extra time, but I'll be happy to answer the questions.
So Dr. Heidari, thank you so much for your presentation today, and all of our viewers. You can tell he is a wealth of knowledge. We don't have time for question and answer now. However, Dr. Heidari has mentioned that you will be able to email him personally, and he will answer questions. So Dr. Heidari, why don't you share with our viewers your email address so they can ask their questions to you directly?
Yes, so it's G, the first letter of my first name, and then Heidari. Actually, I can go to the first slide and you can have my name there. Heidari is Heidari. And then my last name has a second part, which actually I didn't put it here, but it's Bateni. It's Bateni. And the email is LLU email. So it's basically G, Heidari, and then Bateni at llu.edu. If you like, I can share my Gmail as well. I don't know if I'm allowed to do that.
Your Loma Linda is perfectly fine. So if you could repeat that email once more for our viewers, that would be great.
Of course. So it's going to be, let me see if I actually add it here. So I think probably that's easier. So it's going to be G Heidari Bateni at llu.edu.
Perfect. Perfect. And so if any of you viewers out there have more questions for Dr. Heidari, please feel free to email him. And we apologize for not getting them to you today. However, Dr. Heidari, thank you so much for being with us today. This is a very, very important topic that can get complex if you don't have an expert walking you through these things. The great thing about hypertension, which I really love about this topic, is that there is treatment. There is absolute treatment that you can really get healthier, and with medication, with your doctor, with lifestyle, we can actually embrace a healthier life. Now, I want to thank all of you. I want to invite each one of you to our next session, which will be on March 30th. That's March 30th at noon in Pacific Standard Time. And we are going to be talking about your whole health. So your mind, body, and spirit, and you. And we have Dr. Marguerite Azinwa I'm ready to answer your questions. So please you don't want to miss that. So again, thank you all for joining me. My name is Dr. Olivia Moses, and we'll see you next time.